بلش جاهز.
Our next lecture, or the last lecture in this conference, is about implant restoration through digital workflow by Dr. Faisal Al-Rashidi. Dr. Faisal Al-Rashidi is a prosthodontist specialist in Al-Adan Hospital. He obtained his Master of Clinical Dentistry in Prosthodontics from Cardiff University in UK, and a membership of the Royal College of Surgeons in Prosthodontics from Edinburgh, Scotland. حياك الله دكتور.
الله يحييك. Good evening, everyone. As Dr. Asma mentioned, I'm a prosthodontist. I work in Al-Adan Dental Specialty Center. I'll be presenting this topic today to you guys, titled Implant Restoration Through Digital Workflow. So, in brief, I will be talking about a quick introduction about digital workflow, what is the components of digital workflow, what is a CAD/CAM system, and we'll take a look at intraoral scanners, what are they, what do we use them for, and then we'll dive into digital workflow, the advantages of using digital, the disadvantages of using digital, indications, are there any limitations to using digital, and then later on I will be speaking in depth about digital implant workflow, which is specifically targeting how to restore implant using a complete digital workflow. We'll take also a look at the literature review. What does the evidence say? Does it support using digital in restoring implants? And we'll see some cases as well using digital in restoring implants. So basically a CAD/CAM system is a system or a workflow that consists of a CAD, which is computer-aided designing, and a CAM, which is computer-aided manufacturing. And basically, this consists of designing software and a manufacturing software. The first step of any digital workflow will consist of taking a measurement for, let's say, a crown, let's say an implant, and using that, we can use either intraoral scanners or desktop scanners. And later on, we can design our prostheses through a designing software, which is the CAD part. And there are many softwares in the system, in the market. One of them is ExoCAD, other is 3Shape. And then after that, after we design our 3D product, we need to convert that 3D product into a product that can be milled or printed into a milling machine or a 3D printer. And there is also a dedicated software for the milling part or the printing part, which is a CAM software. So this is basically, in brief, the cycle of digital workflow. So what are intraoral scanners? In plain and simple words, intraoral scanners are devices that basically takes the record intraorally and convert that record through light source, through cameras, into a 3D entity. And this is basically what an intraoral scanner does. So it's a light emitting source and combined with a sensor or a camera that will collect that reflected light, and through its software, it will convert that images and stitch them together and put them into basically a 3D mesh. So how can we measure the accuracy of our 3D scanners, whether they were intraoral scanners or lab scanners? Basically, we need to know two terminologies. One is the trueness, and the other one is the precision. Trueness means how close is our image to reality. Let's say I have this, let's say this pen or this device in my hand. If I take a scan of this device and I measure it in my software, it should represent the same dimensions from the reality. So if this is, the length of this device is 2 centimeters, and I scan it and put it in my software, it should be exactly 2 centimeters. So this is the meaning of trueness. How true is our image? The meaning of precision, which is the level of repeatability. How many times can I scan this device, and how many times it can reproduce the same readings, the same measurements. And these measurements usually been taken or usually get tested inside labs. So what we know is if we have a scanner, it should be as accurate as up to 5 microns. And the repeatability, it should, for our scanner to be accurate, it should produce the same image every time, or produce the same result every time we do the scanning. So what are the types of intraoral scanners? Basically, we have 2 types. We have the standalone scanners, and we have the all-in-one scanner. So basically, if you buy a scanner, I'm sure that you've seen today in the exhibition many different scanners. So scanners are either standalone, which is just a scanner itself with the programming of the scanner, or there is all-in-one scanning platform, which comes with a scanner, software for the designing, software for the milling, and also a milling machine. So when we want to buy a scanner, what should we look for? Basically, we should look for a highly trueness scanner, which means that it's very accurate. It produces real images. Highly precise scanner, which means that every time we take a scan, it should give us the same exact correct measurements. It should have a high resolution camera. It should be powder-free. Previously, because of the reflection of the light during scanning, there used to be some scatter happening, and this scatter will affect the accuracy of your images. So they used to use powder, but now new scanners, new generations do not have powder, and they are more accurate. So this is what you should aim for in terms of getting an intraoral scanner. Also, the speed of the scanner should be fast. You should be able to scan the full mouth in few minutes, and maybe less than a minute. It should have a smaller tip, so we know that the scanner has a tip. It goes inside the mouth, we scan. So it should have a smaller tip that will allow us to go and maneuver all around the oral cavity without causing any discomfort to the patient. And it also should be colored. Now, new scanners have colored, the ability to reproduce colored images or colored 3D entities. So we can differentiate between caries, we can differentiate between the hard tissue, soft tissue, etc. And it should be an open system. And I will be talking about open and closed system later on in the presentation. So, is there any advantage in using digital workflow in dentistry? Yes. Evidence has showed that patients who have experienced intraoral scanners or digital workflow in general has less gag reflex, has less discomfort, because many of them have gag reflex, especially children. Not only that, it's time efficient, and I will show that later on in my presentation. It will simplify a lot of procedures for us. There is no need for this analog process, which we need to pick the correct tray, or just fabricate a special tray, and then you'll have your different type of materials to use, and then you have to pour that impression. All of that is being canceled with the digital workflow. Also, we can use them with maxillofacial surgery. I'm sure I can remember Dr. Kamal presented a nice case about using 3D with maxillofacial surgery. It works amazing. Not only that, it's better it has the ability, it increases our ability to communicate with our labs. The lab can see the images, we can see the images, and sometimes in real time, we can send the image, the lab can see, check if there is an undercut, if there is lack of a margin, if the implant not being scanned properly, he can tell us and guide us, and we can retake the scan on the spot. No plaster, no errors, no broken plasters. We can see the models in color as well. The lab can differentiate between the finish line and the gum. So all of these are pluses. And you can show your scan to the patient, and the patient can see and see what problems they have. If they have crowding, if they have a long span with atrophic ridge. So you can explain, it's like an explaining tool to the patient. So all of these are benefits for using the digital workflow and using intraoral scanners in our digital workflow. Are they without any disadvantages? No, they are expensive. Some more than others, and some have closed system, which means that you cannot scan and send to a specific lab you want. You have to be connected to a specific program or a specific brand. So this is a nuisance. Not only that, some come without even designing software. So you can't really design your prostheses in-house. You need to send it to the lab. And some have fees also for sending your scans to a lab. So all of this is a burden on the clinician. It's a learning curve. Not an old prosthodontist type of guy, but I used to work in the postgrad program purely analog. I haven't done any digital dentistry. So it was a really tough curve to climb on. But new dentists have been exposed to digital dentistry, so it's easier for them. And if you put your mind to it, you can achieve so much in digital dentistry. And also, you can't really use it for everything. You guys, prosthodontists, you know the benefit of using impression material. It's mucocompressive. You can compress gingival cuff. You can compress soft tissue. While using the scanner, it's purely mucostatic. You're just taking an image of what's there. So if you cannot see the margin, you will never detect it with the intraoral scanner. And this is, to me, this is the biggest drawback for digital intraoral scanner or digital workflow. So, limitations. What does the literature say? When can we use them and when we cannot use them? Well, basically, we can use them for everything except long span dentures or full dentures. We can use them for everything except full arch prostheses supported by implants or complete removable prostheses. And we'll try to check if this evidence relate to reality or not. So, now we know we have an idea about intraoral scanners, we have an idea how it does work, we have an idea about digital workflow. What's special about implants? Well, in implants, basically, when we're taking a measurement of an implant, we need to represent the position of that implant within the oral cavity in relation to the different tissues surrounding them, which means that we need to know exactly the depth of the implant, the position of the implant to the neighboring teeth. And this is a challenge when using intraoral scanner. And the reason why it's a challenge, because it's difficult to capture the position of implants without having a reference point. So that's why we can't really know the depth of the implant, where it is, using intraoral scanner without the use of a scan body. So basically, a scan body is a part or a prosthesis that we attach it to the implant and we scan it. And this prosthesis or this part will act as a transfer couping. So it will tell us exactly where is the position of the implant in relation to the soft tissue and in relation to the neighboring teeth. And because of that, because of the help of that scan body, we can know exactly, the lab can know exactly, and the designing software can know exactly what's the position of the implant and how can we design it. And with scan bodies, we can have either or. Bone level scan bodies or abutment level scan bodies. And there is a reason why we have two different parts. The first reason is if we have a single tooth or we have a prosthesis that's going to be on the implant level, we need to use the implant level scan body. But if we have a prosthesis that's going on top of an abutment, which is like a double crown or a hybrid abutment, we need to use the abutment level scan body. And with the scan body, we have the digital lab analogs, which goes into the 3D printed model. So, is it accurate? Can we scan implants and make sure that those are accurate scans? Well, we need to know that in order to say that our scan is accurate, we need our scan to be at least a minimum of 100%, 100 micron misfit and 0.4 degree level of deviation. What does that mean? That means that if we take a scan, our final outcome should be away from, or the misfit of our scan should not be more than 100 microns, and the degree of the misalignment between the scan and the reality should not be more than 0.4. So what does the literature, or what does the evidence say? The evidence say, unfortunately, that there are many evidence that shows that the misfit between our scan and the reality, or our scan and the accuracy, is around 226 microns. So it's above and beyond the acceptable level of misfit. And the mean angular deviation is about 2.5, and in some studies, about 10 degrees. So your prostheses, when you design them, will not fit. Your prostheses, when you design them, may fit, but they will cause screw loosening, they will cause screw fracturing, and they might cause marginal bone loss if you do not bind with these numbers. And this is what the literature basically says. So what makes an accurate scan and what makes a poor scan? There are factors. One is the distance between implants. So if you have multiple implants, the more distance between your implants, the more the risk of having misfits, of having poor, inaccurate digital impressions. And that was shown by evidence. So when you have less implants, more distance, you would have more errors in your scan. Other factors: implant angulation, depth, and connection. Are they really relevant? No, they're not. They're not that relevant, unfortunately. Other factors: scan body type. We have two different types of scan bodies. One, or the previous one, or the old generation, was manufactured from titanium. And we know titanium is reflective. So the accuracy of the titanium scan body is poor. On the other hand, the new generations of scan body has been developed. They use PEEK material, which is close to composite material, which they don't reflect light, so they have a higher degree of accuracy, up to 40 microns. So this is a very high level of accuracy. And these are the scan bodies in the CAD software, adjacent to a prepared tooth. Other factors: we have the operator experience. Some studies shown that with some intraoral scanners, the operator experience played a big role in having an accurate impression. In other scanners, however, like 3Shape, for example, the operator experience didn't really affect the accuracy of the scan. And lastly, and this point is connected to the previous one, the type of intraoral scanner. So if you use a new generation, a high-end intraoral scanner, you will have an accurate scan. All generations, unfortunately, did not represent us with an accurate intraoral scan related to implants. Other factors, scanning strategy. Every single scanner comes with a specific scan strategy. If you follow that strategy, you will get a higher degree of accuracy. So stick to the manufacturer's recommendation in terms of how to scan and when to start and when to stop. This will increase your scanning accuracy. So we know from literature that restoring implants using digital workflow is limited to single implants, small span bridges. Can we exceed that? Can we do more than that? Let's see. Let's take a look at the literature. What does it say? I found a recent systematic review in a very well-known journal. It's so recent, it's 2021. It included more than 30 studies. And the conclusion of that systematic review was that they do not recommend the use of digital workflow or intraoral scanners in restoring full mouth implants. But we were taught to critically appraise our studies, critically appraise systematic reviews. This didn't make sense to me, so I dug deeper. And when I looked at this systematic review, I found that it only included one study. And that study was from 2014. So this is a study that's way too old. The intraoral scanner generation was old. Scan bodies were old. So all of these are factors and recipes for misfit, recipes for failure, recipes for, don't do it. So I tried to find another evidence that supports the use of intraoral scanner in restoring full mouth implants. And I found one in the Journal of Prosthodontic Dentistry, but it was old. It was 2019. But we like to dig deeper. How many studies did it include? 20. What did it say? It says that, well, we support the use of digital workflow, the use of intraoral scanners in restoring full mouth implants. It's as accurate as taking a conventional impression. So how come? Why this evidence contradicts the other? It's because the studies included 5 clinical trials, and the latest one was 2019. The previous one was 2017. The previous one to that was 2016. So all of these studies included had newer intraoral scanner generations, had better scan bodies that we can use to correctly align the position of implant in relation to the adjacent structures, intraoral structures. So let's see how can we work through digital workflow in real life. I'll show some cases about implant-retained crowns, implant bridges, and finally, let's see if we can do some hybrids as well using digital workflow. So, first case, nice one, very simple. Patient came with, actually, patient just finished ortho. The orthodontist did not want me to remove her braces. She said, can you do it? I said, yeah, let's do it. Let's crack. So we placed our intraoral scanners. We took an intraoral scanner before and removed the healing caps, placed the scan bodies. We took another scan. We took a scan of the bite, and still the braces were on. After that, we placed the implants. Restored. Patient was happy. I was happy. Orthodontist was happy. This is case number 1. It's fairly simple. Case number 2. Can we restore multiple implants? with crowns, veneers, and implants. Let's check. So this is a video that I've done. It shows the process of taking our impression, taking our digital impression to our scan bodies, to our teeth. As you can see here, I'm scanning the oral cavity, I'm scanning the scan bodies, I'm scanning the paired teeth, and making sure that we dry the field. We don't want any moisture, we don't want any reflective entities on the teeth. And this is the scan of the prepared teeth, of the scan bodies, and this is the bite taken virtually or digitally. And this is the design of our prostheses. As you can see here, this is the part where the CAD comes in. We did our part, we took our records, so we send our records to the lab, and the lab, what would they do is basically design our prostheses, design our crowns, design our implant-retained crowns, and design our veneers. And this is the position of the implants. Amazing positions, amazing. And as I mentioned, the lab can see in colors, can differentiate between the tooth, the margin, the soft tissue. All of that is a benefit for us and for the lab. And after that, they will melt the prostheses on a model. That's why we need digital lab analogs. And this is the final results for our patient, happy patient. So multiple implants done, single crowns done. Can we do other things? Yes. We can always take a record of the soft tissue. We're prosthodontists, we know we want sometimes to record the gingival cuff to better design our prostheses around that gingival cuff. We can always do that. We can remove the healing cap, take a scan of the gingival cuff, and then place our scan body and take another scan and overlap those two scans together. So the lab will have not only the scan, the first scan, they will have the two scans related to each other, aligned with each other. And then they can design our prostheses, and then we can deliver them, and the patient will be happy. Let's take it to another level. Let's do hybrids. Can we do hybrids? We can. Why not? To me, the benefit of using digital workflow is summarized in this video. This is a video of me taking a conventional impression, abutment level impression for a hybrid case. It takes minimum an hour and a half just to splint those together, tie up the floss, put our Duralay, and drill holes in our special tray or even stock tray, and then take our impression. It's very tiring, very excruciating for our patients. But we do it for the sake of perfection, for the sake of producing a very accurate impression. We do it, we have to do it. And it takes 2 hours. Let me skip a part of it, because it's more than 2 minutes. Oh, I can't. Again, it takes a long time, as you can say here. But when you take a scan, it will take 6 minutes. Of course, there is some pause here and there. We do take some rest here and there, but it takes 6 minutes. And the patient is not in agony. The patient does not really gasp for air when we take the impression. You're worried about our impression or our record being incorrect. We always worry about this, so we use a verification jig, right? And it's usually with acrylic. So we can do verification jig through digital workflow as well. Just send the scan to the lab, tell them we want a digital verification jig. And they can just print it. They can just design it in the CAD system and just print it for us. So don't worry, everything is being calculated well, everything is being looked for. So let's see a hybrid case. So this is a case that came to me. It's a single arch. We took abutment level scan with the use of multi-unit scan bodies. Then we verified our scan using the 3D printed digital verification jig. After that, we always take X-rays to make sure that our abutments are fully seated. And then we send our scan and verification to the lab to design our prostheses. As you can see here, this is the scan with the multi-unit abutments. And this is the final results with the opposing inside the patient's mouth. Second case, another hybrid, upper and lower, done here in Kuwait. Scans, upper and lower, done, 6 minutes. Designing of the prostheses in the lab. Of course, in every step, you need to take X-rays for your scan bodies to make sure they're seated before taking your scan. In every step, you need to verify your digital scan afterwards using either conventional or digital verification jigs, just to make sure that your prosthesis, the end product, is passively seated on the implant. After that, I did something extra here. We did a 3D trial to assess phonetics, shape, etc. We adjusted, obviously, on that 3D trial, and then this is the final product. This is the final product using digital workflow. And this is the occlusion. An occlusion to die for. Patient was happy, I was happy. Can we take it further? Yes, we can. We can not only use intraoral scanners, we can use extraoral scanners, guys. Facial scanners. And by some tools, we can align our intraoral scanner with our extraoral scanner. Put them together and design the software. And we can show the patient, before we even finalize anything, the shape of the teeth, shade of the teeth, everything. And this is the final design. In conclusion, and this is probably one of the nicest quotes I ever read, is that due to the digital revolution in prosthodontics over the last few years, the speed of the scientific paper struggles to keep up with the industrial developments. This quote means that evidence, unfortunately, cannot keep up with commercial work. So if you read it in the literature, probably it happened a long time ago, and there are new advances. So we need to know that evidence comes to us in a past tense. When it comes, it already happened. In order to create new evidence, you need to work. You need to experiment. You need to do things outside the box. And when you do things outside the box, you will have problems, you will have issues, you will struggle at first, but then you will find a better way, an easier way to do things. And this is what I found in using dentistry, in using digital dentistry. I haven't done digital dentistry before, but when I started to do, I realized that going back to conventional dentistry and analog dentistry is, to me, it's a waste of my time, a waste of the patient's time. So in short, this is what I think. I think that digital is the next big thing in dentistry. If we don't capitalize on that now, we will be in the past, guys. And that will include my presentations. If you have any questions, I'm open. Surprisingly, yeah, you can get in contact with any lab. To be honest, most of the cases here are done in a lab in Kuwait. So you don't really need a specific lab. Most of the labs now are investing a lot in digital dentistry. So most of the lab, they can do these prostheses. I deal with a lab here in Kuwait. I will tell you that after the presentation. But most of the work is done here in Kuwait. So there's no issues. I deal with different labs all over Kuwait and abroad, but there are some labs here in Kuwait. They deal with digital dentistry all day long, so you shouldn't be worried about this. Yes, I did. We have two different scan bodies. We have multi-unit scan bodies, and we have the regular scan bodies, which are, again, bone level, abutment level. So in multi-unit, all of the multi-unit, we used a multi-unit scan body or abutment level scan body. So when you're scanning, you're actually scanning the second crown that goes into the prosthesis. This is the idea of having the multi-unit scan body. Whenever you have a distortion in your scan body, this is the time you need to throw it. The scan body. The tip, it depends on the manufacturer's recommendation. So some scanners, they recommend a single use. So when you finish with your tip, you just throw it. This is some scanners. Others, they recommend sterilizing your scan tips about 100 times or 50 times, depend on the design, depend on manufacturer. So I would stick with the manufacturer's recommendation for the best results. And calibrating your scanner is very important. Especially calibrating before having a big case. This will do wonders for your scan and the accuracy of your scanners. Then it's definitely a single use. If it goes inside the oral cavity, it needs to be sterilized. If they recommend otherwise, you need to contact them and check exactly what's the protocol for using the scanner tips. Because usually the scanner tips, they go into sterilization. There are two different schools of thought in regards of scanning tips. One is either you have the scanning tip and you have a sleeve, this sleeve that you throw in the bin after you scan, or you have a disposable scanning tip, or you have a sterilizable scanning tip. Those are the three categories. If you have to be in one of them. If you're not in one of them, check with your company. Definitely it has to be one of the three. Any other questions?
Thank you, Dr. Faisal, for the great lecture.